Pharmacology SAQ 15 Hepatic Drug Metabolism. A. How are drugs metabolized in the liver and what factors influences it? 5 marks. In general, metabolism produces a more polar or water-soluble molecule that can be excreted in the bile or urine, which are the chief routes of drug excretion. There are two phases of metabolism in the liver, phase 1 and 2. Phase 1 metabolism involves oxidation, reduction, and hydrolysis. During these reactions, certain groups are added so that the drug can undergo the second phase to produce conjugate products. The actual activity of a drug can be altered in one of three ways by phase 1 metabolism. The new compound can have a similar or different activity to the parent compound, such as tramadol to M1. Secondly, it can be converted from an active to a relatively inactive compound, such as morphine to M3G. Thirdly, it can be converted from an inactive to active compound, such as parecosib to valdecoxib. If the metabolites of phase 1 reactions are sufficiently water-soluble, they can be readily excreted at this point. Examples of drugs undergoing oxidation includes paracetamol, codeine, ropivacaine, omeprazole, and phenothiazines. Oxidation is catalyzed by cytochrome P450 enzymes. This is the most common of the phase 1 reactions. Reduction is catalyzed by cytochrome P450 enzymes as well. Examples of drugs subject to reduction includes prednisone, a prodrug which is reduced to the active glucocorticoid prednisolone, warfarin, an anticoagulant which is inactivated by the transformation of a ketone group to a hydroxyl group, and halotane which undergoes both oxidation and reduction reactions depending on the oxygen tension present. Hydrolysis is catalyzed by esterases and amidases. Drugs with ester or amide groups such as petidine, lidocaine, bupivacaine, and prilocaine undergo hydrolysis. Phase 2 reactions involve glucuronidation, sulfation, acetylation, methylation, etc. This involves the attachment of ionized groups to the drug, and it is this process that significantly increases their water solubility, allowing excretion in the bile and urine. Most phase 2 reactions inactivate drugs, or the active metabolites formed from phase 1 reactions. Drugs undergoing glucuronidation includes morphine, propofol, and midazolam. This is the major route for propofol metabolism, allowing excretion via the liver and kidneys. Morphine is metabolized to morphine 6-glucuronide, which is 13 times more potent than morphine and is thought to play a major role in morphine analgesia. The phase 1 metabolite of midazolam, 1-hydroxymidazolam, is active. Sulfation is responsible for the metabolism of drugs such as paracetamol and propofol. Regarding paracetamol, sulfation is responsible for metabolism of about 40% of paracetamol. A further 40% undergoes glucuronidation. A small amount of paracetamol undergoes N-hydroxylation to NAPQI, which is toxic. Under normal circumstances, this is rapidly conjugated with glutathione to form non-toxic conjugates. However, in paracetamol overdose, this latter metabolic pathway is saturated and NAPQI accumulates, causing hepatic toxicity. Treatment involves N-acetylcysteine, which is a precursor to glutathione. Drugs undergoing acetylation includes isoniazid, sulfonamides, and hydralazine. Acetylation is susceptible to genetic polymorphism. Catechols such as noradrenaline undergoes methylation. For example, adrenaline is metabolized by COMT to metadrenaline, which is metabolized by MAO to vanillyl mandelic acid. Noradrenaline is metabolized by COMT to normetadrenaline, which is metabolized by MAO to form VMA. Factors which may affect the hepatic metabolism of drugs includes age, nutrition, hepatic function, enzyme induction and inhibition, enterohepatic circulation and intestinal flora, hepatic blood flow, renal failure, and genetic polymorphism. In neonates and infants, the activity of cytochrome P450 enzymes is markedly reduced. Some drugs are metabolized more slowly and others by different enzyme pathways from adults. The action of barbiturates and opioids in neonates is prolonged and enhanced. In the elderly, hepatic mass and blood flow fall by about 40% by the 9th decade. Although cellular function is relatively well preserved in healthy patients, the reduction in size reduces clearance and prolongs the effects of drugs that are metabolized by the liver. For example, opioids, propofol, benzodiazepines, and non-depolarizing muscle relaxants. Nutrition. Malnourished patients have reduced metabolism due to reduced hepatic enzyme activity. Hepatic function. Metabolism of drugs are altered in hepatic failure due to changes in hepatic enzyme activity. In early alcoholic liver disease, the cytochrome P450 enzyme system is often induced, leading to rapid metabolism of drugs, whereas this is reversed in end-stage liver disease. In advanced liver disease, reduced liver mass results in reduced metabolism of drugs, and this may potentiate the effects of drugs such as alfentanil, morphine, vacuronium, rocuronium, mivacurium, and benzodiazepines. Decreased portal blood flow in hepatic fibrosis leads to reduced first-pass metabolism and increased bioavailability. The presence of portal cable shunts increases bioavailability by reducing hepatic clearance of drugs. Enzyme inhibition and induction. Some drugs induce the activity of hepatic microsomal enzymes, increasing the rate of metabolism of drugs metabolized by these enzymes, and this may lead to reduced plasma levels of those drugs. Other drugs which inhibit the activity of hepatic microsomal enzymes may result in increased plasma levels of drugs metabolized by these enzymes. Examples of hepatic enzyme inhibitors include sodium valproate, isoniazid, cimetidine, ketoconazole, fluconazole, alcohol binge drinking, chloramphenicol, erythromycin, sulfonamides, ciprofloxacin, omeprazole, and metronidazole. A mnemonic used to remember this is sickfaces.com. Examples of enzyme inducers include sulfonylureas, carbamazepine, rivampicin, alcohol, phenytoin, griseofulvin, and phenobarbital. The mnemonic used to remember this is SCRAP-GP. Enterohepatic circulation and intestinal flora. Drugs excreted in the bowel such as glucuronide conjugates may be hydrolyzed in the small bowel by glucuronidase secreted by bacteria. Lipid-soluble active drugs may result and be reabsorbed, passing into the portal circulation to the liver, where the extracted fraction is reconjugated and re-excreted in the bowel, and the rest passes into the systemic circulation. This process may continue many times. Failure of the oral contraceptive pill while taking broad-spectrum antibiotics has been blamed on a reduced intestinal bacterial flora, causing a reduced enterohepatic circulation of estrogen and progesterone. Diseases or drugs that reduce hepatic blood flow, such as heart failure, shock, or CVS depressants, can reduce hepatic metabolism. Renal failure. Accumulation of uremic factors downregulate hepatic CYP enzyme activity. Genetic polymorphism. Genetic polymorphisms of particular relevance to anesthesia are those of plasma cholinesterase, those involving acetylation, and the CYP2D6 variants. Genetic polymorphism in N-acetyltransferases involved in phase 2 metabolism produces fast and slow acetylators depending on the individual variation of the enzyme. Slow acetylators are more at risk of dose-dependent drug toxicity, such as those caused by isoniazid and hydralazine. Some patients have multiple copies of CYP2D6 gene, all of which are expressed. As a result, these ultra-fast metabolizers convert codeine to morphine very rapidly and experience unpleasant side effects of morphine. Additional information on CYP2D6 polymorphism. CYP2D6 is a microsomal enzyme mainly located in the liver. There are two alleles encoding this enzyme. This enzyme is involved in redox reactions. CYP2D6 polymorphism affects 25% of clinically used drugs. CYP2D6 is not inducible. Examples of drugs activated by CYP2D6 include codeine, which is metabolized to morphine, tramadol, which is metabolized to M1, and oxycodone, which is metabolized to oxymorphone. Drugs inactivated by CYP2D6 includes methadone, SSRIs, TCAs, beta blockers, and clonidine. Ultra-rapid phenotype has more than 2 normal alleles. Normal phenotype has 2 normal alleles. Intermediate phenotype has 1 normal and 1 reduced function allele. Poor metabolizer phenotype has 2 reduced function CYP2D6 alleles. Effects of increased CYP2D6 function. If the drug is activated, there will be increased peak effect and toxicity and increased duration of action. If the drug is inactivated, there will be reduced peak effect and duration of action. Effect of reduced CYP2D6 function. If the drug is activated, there will be reduced peak effect and duration of action. If the drug is inactivated, there will be increased peak effect, toxicity, and duration of action. For genetic polymorphism discussing plasma cholinesterases, kindly refer to the succinylmetonium notes. B. Outline the effects of liver failure on the pharmacokinetics of drugs. 5 marks. In liver failure, there is failure of the liver to perform its functions. A mnemonic to remember functions of liver is MESSHID, MESSHHID, where M stands for metabolism, E for excretion, S for synthesis, S for storage, H for hormonal, H for hematological, I for immunological, and D for detoxification. Associated features of liver failure includes portal hypertension and portal systemic shunts. Effects of liver failure on pharmacokinetics of drugs. Absorption. For drugs administered via oral route, liver failure results in delayed gastric emptying, increased gastric transit time, and slowed intestinal drug absorption. Liver failure may result in diarrhea. This reduces intestinal transit times and reduces intestinal drug absorption. There is reduced first-pass metabolism and increased portal systemic shunt, which results in increased bioavailability and toxicity of drugs. Reduced bile secretion reduces absorption of vitamins A, D, E, K. Liver failure-induced edema reduces absorption via subcutaneous or transdermal route by increasing diffusion distance. Distribution. Increased ECF volume due to liver failure increases the volume of distribution of hydrophilic drugs. This increases the required loading dose to avoid reduced plasma concentrations. Reduced albumin and alpha-1 acid glycoprotein synthesis increases the proportion of unbound drug, and this increases the risk of toxicity. There is altered volume of distribution, half-life, and duration of action. Doses of highly protein-bound drugs may need to be reduced, such as phenytoin, benzodiazepines, aspirin, and warfarin to avoid toxicity. Bilirubin can also compete for protein binding sites. Raised bilirubin levels can increase the amount of unbound drug. Metabolism. Hepatic extraction ratio is drug concentration in hepatic artery minus drug concentration in hepatic vein divided by drug concentration in hepatic artery. Early alcoholic liver disease may induce cytochrome P450 enzymes, leading to rapid metabolism of certain drugs. In end-stage liver disease, there is reduced phase 1 and 2 enzyme reactions due to reduced enzyme activity, hepatic mass, and hepatic blood flow. There is reduced hepatic extraction ratio and reduced clearance of metabolism-limited drugs. With a HER of less than 0.3, more drug will reach the systemic circulation, and increased bioavailability increases drug effects and half-life. Half-life of certain drugs may be increased, for example, thiopental, which may result in prolonged hypnosis. Phase 1 reactions are often affected before phase 2 reactions. Reduced hepatic blood flow may be caused by cirrhosis or use of vasopressors in intensive care. This causes reduced drug clearance if the drug is flow limited with a HER of more than 0.7. Examples include lidocaine. Reduced plasma cholinesterase production may occur, resulting in reduced clearance of succinylmetonium, mivacurium, ester local anesthetics, and diamorphine. Reduced bile production results in reduced excretion of large or lipophilic drugs and their metabolites, increasing toxicity. Examples include vecuronium, glycopyrronium, rocuronium, morphine 6-glucuronide, and rivampicin. Renal failure may be caused by hepatorenal syndrome. This causes reduced excretion of small hydrophilic drugs and their metabolites, resulting in drug accumulation and toxicity, such as morphine 3-glucuronide, which may cause seizure. Additional information: hepatic failure affects pharmacodynamics by several ways. Hepatic failure increases sensitivity of the brain to opioids and benzodiazepines. Hyperammonemia causes hepatic encephalopathy. Reduced production of clotting factors and anticoagulant factors and platelet sequestration causes unpredictable clotting status and unpredictable effect of anticoagulants. Hepatorenal syndrome causes increased sensitivity to nephrotoxins such as gentamicin. There is increased sensitivity to hepatotoxins such as paracetamol, which exacerbates liver failure.